So in this video we are going to talk about myelodysplastic syndrome. This syndrome is characterized by clonal stem cell disorder. That is, in the bone marrow we have clonal stem cells that are highly proliferating. These lead to a maturation defect and we will have lot of immature blood cells now in the periphery. Now two characteristics of these immature blood cells is they are going to die prematurely. Now see what is happening. We have marrow that is proliferating very highly and we have the peripheral cell that are dying prematurely, and we have very low normal blood cell count in the periphery. So we have pancytopenia. That is a trilineage problem. Now this clonal stem cell proliferation in bone marrow and pancytopenia is what is known as ineffective erythropoiesis. Not only this, the immature blood cells are defective and we have an increased risk of AML in this case. And this is important question now. Now let's try to understand more a bit about the pathology and the peripheral blood findings in the case of MDS. So this clonal stem cell disorder is because of a neoplastic multipotent stem cell in the marrow. This has a potential of differentiation, okay, but it has disordered differentiation, meaning we will have a trilineage problem now, and these peripheral findings are very characteristic findings of MDS actually. So we will have problem in erythroid, myeloid and megakaryocyte trilineage problem. Let's see what happens in the erythroid lineage. So we see megablastoid maturation, meaning we will have large RBCs now. Not only large, we will have multi-lobed and multiple nuclei in the RBC, and meaning we will have nucleated red cell progenitors. You see, we have here the large RBCs that are the megablastoid. Note, we have also the megablastoid maturation in vitamin B12 or folic acid or orotic aciduria. Okay, but one more finding we see in a erythroid lineage is we have the mitochondria which are laden with iron, and here we are staining iron blue with Prussian blue stain. So we see erythroid progenitors with iron laden mitochondria, and this is what is known as a ring sideroblast. So two findings in the erythroid lineage is one, megablastoid maturation with multilobed and multiple nuclei in RBC, and erythroid progenitor with iron laden mitochondria, that is ringed sideroblast. What we see in the myeloid series is specific to this condition MDS, that is we have neutrophil with lesser lobes like 2 lobes, and this is what is known as pseudo-Pelger-Hu abnormality. Okay, what we see in the megakaryocyte lineage again is we see megakaryocytic cells with multiple separate nuclei. This condition is known as Pon ball megakaryocyte. So two names, Pon ball megakaryocyte and pseudo-Pelger-Hu abnormalities, is what you see in this case of MDS. Okay, so we try to understand a bit about pathology of this condition. Let's try to understand two kinds of MDS now. The primary one is what is idiopathic condition, okay, but the secondary one occurs following a genotoxic drug, and after around 2 to 8 years we develop MDS. What we are really worried about is the radiation therapy induced MDS, that is TMDS. It is really very bad prognosis. The worst kind of MDS you can get is due to radiation therapy MDS. That leads to an AML within 2 to 3 months of the therapy, and there is maximum risk of AML in radiation therapy. And 4 to 8 months after the therapy is the survival following the therapy actually. So 2 to 3 months you get the ML, and 4 to 8 months is the survival of the disease. What we also need to understand a bit about the pathogenesis of the disease again. A peculiar point to note here is that the epigenetic changes that are seen in the case of MDS are actually same as the AML, meaning the DNA methylation changes we see in AML and the histone modification we see in AML, the factors involved in AML are same as involved in the MDS. Okay, one more specific thing is RNA splicing factor. You just need to remember the name. 3' end of this RNA splicing factor is involved. What is another peculiar thing is in AML, that is de novo AML, we see translocation 821, inversion 16 and translocation 1517, but this is not seen in case of MDS, meaning you will not see any of these mutation in MDS mono MD means alone MDS, you can't see these mutations. What you see is loss of function of RUNX1, that is common mutation in case of MDS. You see monosomy 5 and 7 and deletion 5q and 7q. These are mutations which are seen in MDS, and we have an entity in the MDS, that is CHIP, that is clonal hematopoiesis of indefinite potential. This CHIP changes to MDS in case we have these mutations. So this is another thing you may remember. Now demography wise, you will see a 70-year-old male generally, in which 50% of them will have incidental diagnosis of MDS, whereas the other people will present with, since we have a trilineage problem, the person can present with either of the manifestations. Say if the RBCs are affected, mainly the patient is going to present with anemia and its manifestations like pale skin, weakness and difficulty in breathing. Whereas if WBC are involved, we have the likely decrease in the immunity, and we will have frequent infection as the presentation. The platelet involvement will lead to more of the bleeding manifestation due to thrombocytopenia, leading to bleeding, bruising, okay, hemorrhages. This is how a patient of MDS will present. What we can do for a patient of MDS is, if the patient is young, you can go for allogenic hemopoietic stem cell transplantation. But in an old patient, this is not an option. So you go for blood products to manage the patient, you give antibiotic in the cases of repeated infection, and you support the patient, you give the supportive treatment. We also found use of thalidomide like drugs, okay, and DNA methylation inhibitors in case of MDS. Specifically, it improves the hematopoiesis in the patient. So these were bits about MDS, and this is a high yield topic in recent exams of INI. Hope you liked it. Thanks for watching.